Good afternoon, everybody. Happy Recovery Month and welcome to this afternoon's session on telehealth's role in behavioral access and outcomes. My name is Trina Dutta, and as of yesterday and this week, I am the Chief of Staff to SAMHSA's Assistant Secretary for Mental Health and Substance Use, and I'm so pleased to be with all of you today, and I'm really excited about our excellent panel of speakers. As you hopefully know, SAMHSA's mission is to lead public health and service delivery efforts that promote mental health, that prevent substance misuse, and provide treatments and supports to foster recovery while ensuring equitable access and better outcomes. Our vision is that people affected by or at risk for mental health and substance use conditions receive care, achieve well-being, and ultimately thrive. As all of you know, we are in the midst of a behavioral health crisis. We know that from 2021 to 2022, the number of deaths by suicide increased by 2.6% to almost 50,000 deaths. We know that more than 140,000 people die each year from alcohol-related illnesses, and that in 2021, more than 106,000 people died from drug-involved overdose. The need for increased access to behavioral health care is critical, and certainly telehealth is an invaluable pathway to ensuring more equitable access to life-saving services. To address this crisis, telebehavioral health can break down barriers to receiving care in a number of ways. It can increase access to treatments and specialists. It can enhance privacy. It can decrease feelings of stigma. It can increase convenience to the patient or client, and it can expand the network of behavioral health providers. Telebehavioral health has the potential to close the gap and address the unmet behavioral health care needs that we're experiencing across the United States. It is for this reason that SAMHSA really strongly encourages use of telemedicine to expand access to services and to alleviate workforce shortages. And particularly this is happening through our Certified Community Behavioral Health Clinics program, our CCBHCs, and through our block grant programs. Because of the potential telehealth has to making treatment services more accessible and more convenient, to improving health outcomes and for reducing health disparities, last year SAMHSA published an evidence-based resource guide entitled Telehealth for the Treatment of Serious Mental Illness and Substance Use Disorders. And I really encourage everyone to check that out. This reviews literature on the effectiveness of telehealth modalities for the treatment of SMI and SUD. It distills the research into recommendations for practice and provides examples of how practitioners use these practices in their actual programs. And in May of this year, just a few months ago, SAMHSA worked with the DEA, the Drug Enforcement Agency, to temporarily extend COVID-19 telemedicine flexibilities for prescribing controlled medications while we're considering comments from the public that were received as part of the published rulemaking. So today we have a really great panel for you this afternoon to discuss telehealth's key role in access to behavioral health services. Joining me is Chris Four from the Indian Health Services within the Department of Health and Human Services, Donna Dittman-Hale from Bay Rivers Telehealth, and Janet Orwig from the Association of State and Provincial Psychology Boards. I'll let each of our panelists introduce themselves further, and you can find more information about them from their bios located on the conference website. After we hear from all of the panelists, then we'll have some time for Q&A. And if you have questions during the sessions, I encourage you to share them with us using the Q&A icon in Zoom. So now I will turn to our first panelist, Chris Four with IHS. Chris, please go ahead.
Great, thank you. I appreciate the introduction, and let me share my slides with you all. All right, Okay, there we go. Again, thank you for the opportunity to speak to you a little bit about telehealth and telebehavioral health in particular, and what we're doing within the Indian Health Service. Many of you may not be aware of Indian Health Service, so I may spend just a little bit of time orienting you to what our agency does. As previously mentioned, we're part of Health and Human Services, And we provide healthcare to the American Indian and Alaska Native population in this country. There are 576 federally recognized tribes that make up our user population. And just to give you a little bit of context, there are more tribes within this country than there are countries in the world. A lot of people aren't aware of the amount of tribal diversity within the United States. It's pretty extraordinary. Um, Related to that, unfortunately, American Indians, Alaska Natives in this country suffer some of the highest health disparities that you will see in any population, especially around behavioral health issues, substance use, suicide, depression, but also on the medical side, especially with diabetes, heart disease, things like that are also very large disparities within this population. Unfortunately, the population as a whole is the most impoverished in the United States as well. So not a lot of individual resources necessarily. And they're also, many of our tribal partners are very remote, especially you think about Alaska, but even in the lower 48, we have reservations where it is hours to get to a specialty care physician or service. So telehealth is something that we've really tried to focus on. Um, as I said, or as we said earlier, I run the IHS Telebehavioral Health Center of Excellence. I'm a child clinical psychologist by training, and I'm a member of the Choctaw Nation of Oklahoma. I did my graduate work at Oklahoma State, undergrad at the University of Oklahoma, and started this program about 14 years ago just to see if it was viable to do telebehavioral health in Indian country. And obviously we're here and it has been a success. It's been a slow start 14 years ago, but things have really taken off during that time. Currently, we have 23 sites scattered around the country. We are literally coast to coast, border to border, serving IHS facilities, tribal facilities, and even some urban Indian programs that are dispersed throughout the country. We provide a full suite of behavioral health services from prescribing to counseling to groups, child work, adult work. We really try to cover the gambit because that's what our sites and our tribal partners need. So just a quick disclaimer that, this information is accurate as of now, and this is, just an informational webinar that I'm giving here. One of the things I wanted to talk to you a little bit about, because I think it's important to see this context of telehealth, telebehavioral health, and telehealth overall, is a provider survey we just did. So we did our initial provider survey right as the pandemic hit. It was in November of 2020. And because of that survey, and we'll talk about this a little bit more in the future, we actually changed the way we did telehealth. And so we wanted to follow up a little bit later on. This was last month, 2 months ago, I guess, and see if there were any changes here. We don't have all that compare and contrast yet because this is sort of hot off the press, but we do have some ideas here about what was going on with telehealth. One of the things you can see is that just in the last 2 weeks, the amount of people doing telehealth within our system, still not a lot. We will see some different data on that or a different look at that data. What we did see is during the pandemic, telehealth really went up and then it's come back down, but it's still above the baseline where we started prior to the pandemic. So the pandemic has really driven sort of a system change within the Indian Health Service. And one of the things we like to look at was, how our providers are feeling about telehealth and whether they feel that it's helped their patients. And the very long story short here is you can see that, yes, sort of across the board, the overwhelming response is that, yes, telehealth is helping patients, that their patients seem satisfied, that has improved the healthcare and improved, as we're talking about during this panel today, access to care. So it's sort of a win for us all across the board. This is our provider survey, so that we're not directly accessing patients here. I'll talk about that in a minute, but our provider's perception is that telehealth, those that are using it, it's been a great experience for the patients. What about problems? This is one of the things that often comes up, and especially when we started doing this 14 years ago, technology was very challenging back then. Fortunately, it's gotten a lot better. So we ask about difficulties with the technology with our providers, and you can see 40% or sometimes was our biggest response here, that 64% said that they sometimes have a problem with the telehealth connection. Um, that's something we're going to be monitoring. We do have a new telehealth platform that we'll see if that changes, but it's something that we need to be aware of. And you know, one of the things that's a very big challenge for those of you who are doing telehealth, oftentimes it's hard to figure out where that problem is. Is it on the patient's end? Is it on the provider's end? Is it hardware? Is it software? Is it connectivity? There are many variables that can create difficulties and problems within a telehealth connection. So as we get more data, we'll try to drill down into that a little bit more. Again, looking at what our providers said, that the vast majority of them would like us to offer more telehealth services for our patients. We're just looking into what some of those may be. We did do an open field so they could reply to that, but a lot of behavioral health, a lot of primary care, also a lot of follow-up. One of the things that we've noticed is that, you know, if you come in for an appointment and you get a lab done, historically you would come back in to get the results of that lab, and why not do that over a telehealth connection rather than having someone drive 2 or 3 hours for literally a 5 or 10 minute discussion. So we're looking at ways that we can maximize our telehealth services and minimize our patients' travel and access to care. So this is the chart I wanted to show you, I referred to previously. So you can see the gray line at the bottom is telehealth. And that's the one I want you to focus on for now. You can see prior to the pandemic, over on the left-hand side, February 2020, it looks like we had no telehealth visits. We actually did. It was just very, very low. But you can see as the pandemic hit, we really ramped up a lot. And it is still, you know, never replaced the in-person, but it has brought it closer. And as if you go to the right-hand side, you can see over time it's dwindled off. That is expected, but we're still well above where we were prior to the pandemic. And I will say this is all telehealth. This is not just telebehavioral health. So, you know, we are continuing to, I think, stabilize at a baseline of telehealth that is quite a bit higher than what it was. It was less than 1% of all visits prior to the pandemic. And now we're currently around 6%. So the 6-fold increase or more is pretty amazing. I'm hopeful that this will continue to take a ramp back up, if you will, and take a climb out of this little dip here, but we will see. But the lesson here is that things have been reset. One of the things, and you may hear this from others, but for us that's been very challenging, especially during the pandemic, was reaching into people's homes and other settings. Within our tribal communities, many of them have connectivity issues. Many of you probably heard of the digital divide. It is real. It is very challenging. On the telebehavioral health side, most of our behavioral health clinics, they shut down all the way to in-person visits. So we had to pivot hard from doing in-person clinic visits to trying to reach people in their homes. What this will show you, if you look at the gray bar, that is televideo connections. The yellow and the blue, that's audio only. So while we were doing a lot of telehealth, the vast majority was audio only, phone calls, if you will, or connecting through an app that is still audio only. So we have struggled and did struggle, especially reaching outside of our clinics to get video connections going. That is something we're aware of, we're working on. We'll discuss that here in a little bit, but it's something for you to be aware of. And if any of you have attended or seen any of the VA data, it looks pretty similar to this, with them trying to reach veterans in settings outside of their C-box and other clinics. I think because their population could be highly rural as well, this data looks very similar to the VA. We sort of covered this. I'm going to skip over this one. I want to talk a little bit here. These are telebehavioral health visits. So now we're getting into our telebehavioral health specifically. And there are 5 regional or national telebehavioral health programs within an in-health service. My program is the national one. There are areas that run their own regional telebehavioral health programs, so that data is included here. And there are some individual sites who have their own telehealth provider or telebehavioral health providers. So you can see this data here. again, the take-home message, you see it really ramp up, sort of go across, up spikes here and there, and then sort of dip back down. But as you can see here, our reset is quite a bit higher than for telehealth overall. Previously, we were, looking around 1,800-ish visits per month, and now we're hovering around 5,000-ish. So we are still quite a bit above where we were prior to the pandemic. This is another way of capturing this by IHS area. So what about next steps? What are we trying to do here now that we have some of this data? One of the things we're trying to do is establish a national program. IHS does not have a national owner or of office of telehealth, so we're trying to get some funding and establish that. So we'll have a little bit better view of what we're doing and a little bit more standardization. We're continuing to do outreach. One of the things that we're very happy about with telebehavioral health is that in the past year to 18 months, social workers and psychologists within IHS have gotten a pay increase. This is allowing us to compete a little bit better against private sector and the VA. Historically, the VA is paid significantly more than IHS. Now we're on a little bit more level playing field. And also, we are now petitioning to get access to licensed professional counselors. The VA just got that job class given to them by Office of Personnel Management, OPM, and we're asking for that to be able to come to us so we could hire another provider type to expand our access to care through different types of behavioral health providers. We are addressing technology issues. We have a new telehealth platform called AA Ring MD that is very robust in low bandwidth, high latency environments. So we're hoping we can reach out of our facilities better and into patients' homes, schools, chapter houses, libraries, things like that. We're going to be testing peripherals. While that's not so important for telebehavioral health, if we want to expand the types of services that we're doing, having all sorts of medical peripherals that can be connected to the telehealth device is going to be really important. I'm running out of time here, but just to give you some information, you can join our listserv and have a discussion with us about telehealth and mHealth, mobile health within Indian country. You can click here and do that. And you can come and visit us at our website, the ihs.gov telehealth website, and find information there about what we're doing IHS-wide as far as addressing telehealth and trying to make sure we can increase access to care to all of our patients. I'm going to skip over the questions. That's going to come later. If you have something you want to throw in chat, please do that. Here's my contact information. Feel free to email me with any questions or comments. And with that, I'm going to turn things over to Donna. Thank you very much for your time today.
Thanks, Chris, and hello, everyone. It's so good to be with you this afternoon. I want to thank HRSA, the Office for the Advancement of Telemedicine, and the Federal Office of Rural Health Policy for inviting me to share just a snapshot of some of the innovations some of our rural champions have implemented and are looking at implementing to address behavioral health and substance use disorder. Next slide, please. Bay Rivers Telehealth Alliance serves the Eastern Virginia rural area. It's hard to believe that just about a little less than 3 hours from the DC area, many of our citizens are still without broadband or cell service. But we serve the Middle Peninsula, the Northern Neck, and the Eastern Shore. So you can see it's all bay and rivers. So thus Bay Rivers Telehealth Alliance. We're currently serving 12 counties in Virginia, but our partners serve much of Eastern and Southern Virginia. Next slide, please. Our partners include, our members include agencies on aging, the Workforce Investment Board, a network of federally qualified health clinics, 2 community services boards, 2 academic medical centers, a free clinic, addiction medicine provider, a community college, a regional health system, and the regional health departments in Virginia, plus over 60 different partners, including schools, EMS, state, federal partners, and it's a wonderful consortium. We are an alliance. Next slide, please. Air Rivers Telehealth Alliance has been around for 20 years. Do you know how far telehealth has come in 20 years? It's hard to believe. We were started by a regional area health education center in 2003. And in 2007, we became a separately incorporated 501c3 and adopted our new name. Since that time, we've really been a one grant wonder, one grant at a time. And then about 10 years ago, we began to bring in more grants. And I'll show you, not to say here's the grants and here's the programs, but how all these grants are braided together into a comprehensive service system. The Alliance staffing itself brings expertise in grant resource development, project management, evaluation, consortium development, while our partners deliver the services. In 2018, we were honored to be named as one of HRSA's Rural Health Community Champions for our work in adapting and adopting evidence-based promising practices. And we are listed on the Rural Health Information Hub for our practices around remote patient monitoring and chronic disease management, for chronic disease management and the COPD toolkit. Next slide, please. Next slide, please. So as I mentioned, we have really had partnerships with all different federal offices, the Federal Office of Rural Health Policy, Community-Based Division, Office for the Advancement of Telehealth, USDA, Distance Learning and Telemedicine Program, and also with the Virginia Department of Health and the Virginia Healthcare Workforce Development Authority. Next slide, please. And we're currently have added to our group of collaborating funders the Substance Abuse and Mental Health Services Authority, and are working hard to manage these grants and coordinate in project teams. Next slide, please. So when I looked at describing the range of mental behavioral health and substance use services that BRDA has facilitated among its members and partners, it really ranged from the whole lifespan. Early on, we got involved with geriatric behavioral health, funded by the Telehealth Network Grant Program. We brought psychiatric geriatrician consults into rural nursing homes that had never had that level of care. At that time, we were buying these carts that were the size of filing cabinets, and then it evolved very quickly into bedside tablets that patients could hold or set up on their bedside stand. We also have been involved in providing home-based remote patient monitoring and chronic disease management, which included behavioral health supports using a PHQ-3 and SBIRT modified on the tablet, asking patients questions about how their day was going. In addition, we funded community-based behavioral health care from site to site for older clients of the Community Services Board who could go to their local community services office and consult with a geriatric psychiatrist on the southern end of our service area. We have conducted several different research studies on these, and just one of them is listed here with a link that talked about the return on investment for elderly long-term care. And we found that the first year is really the capital investment. This is back when we were buying those file cabinet sized carts. But after the second and third years, 7,000 seniors were served, and the return on investment increased within that health system by 34%, primarily due to indirect services, although that included a reduction in emergency room visits, an increase in outpatient visits, and about the level rate of hospitalizations. Next slide, please. The next grant from the Telehealth Network Grant Program was for a school-based telehealth initiative. And that was awarded in 2018 and extended through 2020. Or actually, we had a no-cost extension, so I think we actually went to 2021. And while we had intended to provide primary care and dental care and behavioral health, what really took off was the behavioral telehealth. And COVID happened. Schools shut down. So schools were no longer providing primary care through the school nurse's office. But the in-school counseling shifted to in-home counseling, and COVID visits, mental health, behavioral health visits increased by over 53% from the fall of 2019 to the spring of 2020. And our counselors and family services organization were able to be fully trained. 100% of their youth and family services staff were trained to provide behavioral health services in a very short time frame, thanks to the flexibilities of this telehealth network grant program and the USDA, who supported that pivot to telehealth as a sidebar to telehealth as the main event in 2020. Our providers have also been very involved in SUD risk reduction and early intervention, and we were delighted to receive a grant through the SAMHSA Youth and Family Tree Program this past year to continue our work to provide substance use risk reduction, early intervention, and treatment to youth and adolescents, in part through school-based programs, home-based telehealth, and facility-based, including family services and recovery supports. And we did participate in the national study conducted by the Telehealth Network Grant Program that is published in the Journal of School Health, which also demonstrates that youth increase their number of visits per student from 2.4 per year to 4.1 for existing students. And that first semester in 2020, when all the students came home from school, those new students received 6.5 visits to support the trauma that we all experienced when our world shut down. Next slide, please. Currently, we have 4 different grants through the Rural Community Opioid Response Program, administered by HRSA's Federal Office of Rural Health Policy. And our partners have implemented various innovations to ensure that our community has access to substance use services and response. And the first grant started in the fall of 2020, so became very essential for us to be focused on telehealth delivered services, including developing a bridge to treatment through the emergency department and through emergency medical services. Many of our providers, our EMS providers, would tell you that they would go to revive somebody in their home who'd had an overdose, and they would refuse then to go to the emergency department. So our partners, again, pivoted to address this need by making it possible for people who needed that kind of help to access it from their homes directly to the emergency department via phone, audio only, and if possible, via video as well. In addition, our emergency departments were geared up to provide induction and medication-assisted treatment if appropriate at that point. And then they were able to transfer people into outpatient medical-assisted treatment, as well as all the wraparound services that are needed to really successfully address addiction, including individual and group counseling. We had virtual peer support, one-to-one coaching and in groups, as well as patient navigation via telehealth. In addition, one of our partners have mobile vans that offer on-site treatment and supports to people in correctional institutions. And another, our FQHC network, is providing a telehealth hub for office-based addiction treatment in all of their centers throughout Virginia, as well as telehealth triage and integrated behavioral health care. Next slide, please. So what are our challenges and opportunities? Access to wireless and broadband is still an issue for a lot of people. If they may have the signal, but then they don't have the devices to use. So we're very excited in Virginia that just yesterday, our state announced that they plan to have functionally universal broadband access by 2028, thanks to the funding that was formally discussed on the session by the FCC, the BEAD funding, and the digital access projects. So far, 1.32 billion has been invested, and we're anticipating 1.48 billion more through the BEAD program. Currently, there are 160,000 localities in Virginia that lack reliable access, and 134,000 of those are unserved. They have no service, and the remainder are underserved. So this is a really critical effort that is needed. Transportation is still a need. While telehealth does address many of the needs, there are some things in substance use treatment and serious mental illness that need a face-to-face in-person assessment and lab work. So we continue to utilize our grant funds and seek other funds to help people get to providers, to peer recovery supports, and to medical facilities when needed. Capacity and stigma related to the adaptation of technology. And one of our earlier speakers talked about the use of apps and wearables and how can we integrate that into behavioral health and substance use services is essential. I think I missed the adequate and capable workforce. I don't think there's been a session today where we weren't all expressing our concerns about how to build an adequate and capable workforce. It's not just having enough people, but it's having people who have the skills to effectively deliver telehealth services to make a difference and not just patch over until you can get in there in person. So with our projects, we've focused on training the upcoming workforce in nursing programs, in medical programs, in all programs, including medical assistance, so that telehealth is just part of the understanding that is what the workplace includes. And we've worked with certifications for and credentialing for behavioral health professionals, supporting that, and training both professionals and paraprofessionals in specific case needs. Also, the opportunities for precepted practice where they can be actually supervised and get additional skills in using telehealth technology to deliver care. Our board is also looking at the applications of other kinds of virtual health innovations, including AI and remote patient monitoring and wearables. So before we end, I want to talk a little bit more about digital health literacy, another theme we've heard throughout our day of speakers. And if you take a look at the next slide, there are these generational differences in device ownership and utilization. Next slide, please. And a recent study conducted by a group called Airship took a look at the use of apps to improve health and well-being across generations. And what they found is that in general, 81% plan to use mobile apps and wearables to improve their health, 94% of Gen Z, but when it comes to the baby boomers, it's only about 65%. 35% have no intention of using apps or wearables to improve their health and well-being. And little do they know that it's likely that in their lifetime, as they have more exposure to the healthcare system, we will be asked to use some of these apps and wearables by our healthcare professionals. In addition, low-income households are also limited, with only almost 25% who wouldn't use health and fitness apps even if they could afford them, or were given them. So there are some barriers to utilizing telehealth and virtual health across generations. I actually talked with a younger person recently who's hesitant to use her patient portal. She'd much rather talk to the people in person, and yet that does hinder her access to healthcare. So in conclusion, and as I look at my final slide, please, we were all reminded yesterday in remembering 9/11 that heroes rush in to the site of crises to save lives. And from that lesson, I think we can take that true leaders will rush in and reach for innovation and foster collaboration in times of challenge. And I think we can all agree we are in those times. Thank you so much for inviting me to be part of this presentation. Oh, and now I am going to hand the presentation off to Janet Orwig. Thank you.
Good afternoon. Thank you for allowing me some time to talk with you today about SIPACT. So ASPPB has been very fortunate and very grateful to have been the recipient of several licensure portability grants from HRSA, and we are currently in the 5th year of a 5-year grant. So what is ASPPB? It is the Association of State and Provincial Psychology Boards. That is the association made up of all the licensing boards for the US and Canada in regard to psychology. We have 66 member jurisdictions, and I'm happy to announce we just recently added a new one, which got us to the 66. We added the Northwest Territory. So we continue to grow, which has been really helpful, and we've been very fortunate for that. But we're here to talk about SIPACT, and SIPACT's language was approved by the ASPPB Board of Directors in 2015. And what that meant was that the licensing boards had approached ASPPB about telepsychology, and they were concerned that they did not have the mechanisms that they needed to regulate telepsychology. So ASPPB created a telepsych task force to work on that. So from 2011 to 2015, the association worked on various mechanisms trying to figure out the best way to help with this issue, and the compact actually was the vehicle that was chosen to do this. So I think, as you all know, licensure is required to provide services in most professions. And I think we've seen today during all the presentations that a mechanism for quick and easy licensure portability is really, really helpful and is needed. And so SIPACT is one of psychology's mechanisms used to advance licensure portability. And so what is SIPACT? It is the Psychology Interjurisdictional Compact. It is an interstate compact. And I know that Lisa Robin discussed earlier, right before this session, I think, about compacts and what they do. So just a little bit, just kind of to add on to that it is a contract that the states enter into via the legislative mechanism, that a compact's language has to be enacted in the state legislature as it is written by all of the states that join the compact. Now, SIPACT's a little different in that it is designed to regulate telepsychology and temporary in-person face-to-face practice of psychology. So if you want to do telepsychology, you can do that, and there isn't any time limit. The temporary in-person face-to-face component does have a 30-day time limit. You can practice into another SIPAC state for up to 30 days in a calendar year. And any part of a day is considered a day. And SIPAC only focuses on psychology and psychologists. So as I said, ASPPB created SIPAC, but in July of 2019, the SIPAC Commission was formed. And at that point, SIPAC became freestanding. It is no longer part of ASPPB. It is considered a semi-quasi-governmental agency, and the commission is made up of one representative from each of the compact states. So that's what composes the commission. So some benefits of SIPAC is that it does increase access to care. We've heard that through some other things. It also facilitates continuity of care. And, you know, one of the things that we were hearing when COVID was shutting down everything was we were hearing from the universities, and they were trying to figure out a way to continue services to their students as they sent them home. And that's exactly what SIPAC was designed to help with, was that continuity of care. It also offers a higher degree of consumer protection across state lines because it lays out how the disciplinary process works between the two states, the state where the psychologist is and the state where the consumer of the services is. It also gives the practitioner an ability to have a better understanding of legal requirements. So if you look at the temporary component, when a psychologist is wanting to practice temporarily into a state, go physically into a state, those requirements vary across the state quite widely. Some states will allow you to come in for 5 days, 10 days, 15 days. Some want you to get a temporary license. Some want you to notify them. So it's a wide variation. And so if you are practicing the temporary component under SIPAC, you know you have 30 days and can go into that state, and you do not have to notify the state, and you do not have to get a special license or anything to do that. You already have the authority through SIPAC. So it helps to understand the legal requirements. And it's also more efficient for the provider. And I'll talk a little bit more about that later. You know, we've also heard everyone's been talking about workforce, and it really does help with that. Psychology is a much smaller profession than some of the other professions that have been talked about today. And we are looking at some of our licensing boards have as few as 200 psychologists licensed. So being able to have providers come into their states that may be able to meet specific needs is really, really helpful, as they can be done through SIPAC. And one of the things that as we were going around doing education this year, one of the examples that was shared that I hadn't really thought about was that if you were trying to provide services to a divorced family and you have one parent in one state and another parent in another state, SIPAC allows you to do that therapy together because you're able to do it via telemeans as long as those people, all the parties are in a SIPAC participating jurisdiction. So the layout of it and how you get to be able to have the authority to practice under SIPAC is that there is an application process. You go to SIPAC.org and start your application. In order to practice under SIPAC, you have to have the authority to practice interjurisdictional telepsychology, or an APIT, to do the telepsychology component, and you have to have the temporary authorization to practice, or the TAP, to do the temporary component. And those both are issued by the SIPAC Commission. The SIPAC Commission is the only one that can issue the authority to practice under SIPAC. Now, there is another certificate that is a component of the application. So if you are applying for the APIT, you would need your e-passport application or your e-passport first. And so when you go to apply, you're going to apply for the e-passport. Once you have obtained that, then your APIT application opens up, you finish that, and then the commission gives you that authority to practice telepsychology. Having an e-passport by itself is not sufficient. You have to have that component from the commission to be able to practice forward. Same thing kind of applies to the temporary component, in that you have to have the interjurisdictional practice certificate, or the IPC. And once you have that and have met the other requirements, you can roll into your TAP application and meet those requirements. And then you are able to practice temporarily under the authorization of the commission. So kind of how it practiced, I'm going to focus on the telepsychology component. So if you are a psychologist and you are sitting in your home state, and I'm going to pick on Georgia because that's where I am today, that's my home state. So sitting in home, you've got your Georgia license, you've got your APIT authorization from the commission, and you have declared your home state as Georgia in the SIPAC software. Then you can see via telemeans any patient in any of the other compact states. You do not have to get a license in those states. You do not have to get a privilege, and you do not have to notify the state that you are practicing in there. One of the things you do have to do, though, is you do have to abide by the scope of practice laws in that receiving state. And that does include any laws that cover health and safety of the patient for that state. So you're functioning under the authority of your home license, but you're able to practice into those receiving states under the scope of practice provided in those states. So kind of our status, where we stand right now. Kind of wanted to share this because you can see the growth that we have done through the years with our legislation. As I said, when SIPAC was created by ASPPB in February of 2015, they approved the language. Well, it was a little late for the 2015 legislative session, so we really had one jurisdiction introduced, but it didn't go anywhere. So we were ready for 2016, and we had our first jurisdiction enact the legislation, and that was Arizona in 2016. We made slow progress until 2019, where we got our 7th state. So Georgia came on in April of 2019. And why that was important was they were the 7th state. And the way the SIPAC language was written, we had to have 7 states to stand up the compact and begin implementation. And so we were able to do that. The commission had its first meeting in July of 2019. And like I said earlier, it is now a freestanding entity after that meeting. What we have seen so far this year, as far as legislation, is we have seen 12 bills that were introduced, and 6 have been enacted so far in 2013. That gives us, and I kind of do a drum roll, 40 enacted jurisdictions, and 39 of those are effective. So like I said, we had 6 bills enacted this year. We saw Wyoming become effective in February of 2023. We saw Rhode Island and Florida become effective on July 1st. South Carolina became effective on July 17th. North Dakota became effective on August 1st. And Vermont, even though the legislation was introduced this year, didn't become effective until, or won't become effective until July 1st of 2024. So we still have some active legislation. We have a bill in Massachusetts as well as in New York. Haven't seen a whole lot of activity on either one of them, but we're keeping our fingers crossed. The sessions don't end until the end of the year, so we are hoping that we'll see some movement as it gets a little bit closer to the end of the year. But right now, they really haven't. They've been assigned to a committee, and that's kind of where they have been sitting. So I want to have a little bit of fun with numbers here. So we opened our applications in July of 2020, and as right before this presentation, we have issued 10,640 APITs, or the Authority to Practice Interjurisdictional Telepsychology. And we have issued 578 TAPs. Now the TAPs have been a little slower, and I think the tele part has been the most interesting part going forward. We have seen a little bit of an increase as people are going back into feeling more comfortable being in person. So we are seeing them increase, but very, very slow. When looking at the APIT numbers, that is running about 13% of the eligible licensees in the 39 SIPAC states. So we've been running a little bit about 10%. We're up a little bit, so we've been encouraged about that. And then the other part I kind of wanted to share a little bit about was why I would say it was more efficient or effective for a psychologist to practice under SIPAC is that in order to obtain your authorization, you're going to have an application fee that is going to run you $440. That includes the e-passport and the APIT fee, and a $120 renewal fee. And if you want to do the temporary component, that's $240 application fee for the IPC and TAP, and a $70 annual renewal fee for the IPC and the TAP. So looking at one of the other programs that our HRSA grant funds is the Center for Data and Analysis on Psychology Licensure. And that is where you can go and find everything you might possibly want to know about psychology licensure. We gather all of the information and have just recently put out our 2022 data. So the ASPPB in Focus document can be found on the aspppbcenter.org. And so what I've done here is pull just the general average licensure application fee and the general application or license renewal fee. And so on the website, you'll see a larger number because that does include the Canadian jurisdictions. For these numbers, I only use the US jurisdictions. So on an average, you're seeing $346 application fee for every state that you would want to practice in, and a $315 license renewal fee for every state that you want to maintain that license. So when looking at the cost to get started and being able to practice into all of the 39 effective SIPAC jurisdictions, we tried to make it as cost effective as possible, is so that you would have psychologists hoping to be able to provide those services because it was feasible for them to do so. You can, if you would like to verify an authorization holder, we have that on our SIPAC authorization, verifysipac.org. And right now, it just pretty much your search for APIT holders, and it's going to give you a psychologist name and some license information and things like that. We are enhancing our directory. The APIT and TAP renewals do not start until October 1st. And so when they start, we have added a questionnaire that we will be able to gather more information. And what we're kind of looking at is areas that you practice in and languages that you speak, so that we can add that as search features in this directory so that the consumer can find the practitioner that meets their needs. So if you practice eating disorders, or you work with you speak Farsi and somebody is trying to look for somebody that would meet that language, they'll be able to do that expanded search in the directory. Like I said, our renewals do not start until October 1st, so probably looking at about the middle of next year before we'll have enough data to start beefing up the directory, but we are looking very forward to that, because the best part of this is going to be able to match up the consumer with their appropriate practitioner. And so that's what we're hoping this added to this directory will help do. So has been mentioned, I think, like I said, I think Lisa Robin mentioned in covering that a lot of professions are utilizing compacts to address licensure portability. There are two other mental health compacts. There is the counseling compact, and it is my understanding that they have their magic number. They have the number of jurisdictions they need to start implementing, which means they've been working on their bylaws, their rules. I think they are working on their software for their application process and are looking at or hoping to, in early 2024, open up for applications. Social work has also got their model language, and they have it out there. It has been enacted in a few states, but I don't think they've reached their magic number yet to be able to start their implementation process. But I am sure that this is the links to both of their website, which would have much more information about how their compacts work and where their status is. If you would like more information about SIPAC, our SIPAC website does contain that. You can go there and apply. There is a link to applying for the authorizations to practice under SIPAC. We also keep our map there as current. We also provide links to current bills. So if you wanted to check on the Massachusetts bill or the New York bill and see where it stands and what the language looks like, you can do that from our website. We also provide information about all of our commissioners. Like I said, there is one appointed for each state. And then we also, everything that the commission does is public. So all of our meetings are conducted publicly, and you can find information about going to those, any of those meetings, and the links to be able to do that virtually. And if you have any other needs for further information, here is my contact information, as well as Gina, who works with us and is our SIPAC specialist. And thank you very much for the time.
Great. Thank you so much to Chris, Donna, and Janet for their presentations today. They were so informative. And I was taking a lot of notes, as I hope everyone else was as well. So I think we just have a few minutes just for maybe one question. So I think we'll start with the kind of big elephant in the room whenever we talk about the current kind of behavioral health situation the country is in, and that's around workforce and, you know, the real challenges that we're seeing around the behavioral health workforce shortage. So I'd be curious to hear from our speakers. I know, again, we don't have a ton of time, but can you talk a little bit about, from your perspective, how telebehavioral health can help with kind of strengthening the behavioral health workforce, either the quality of the workforce that we have, or using it as a way to enhance access. So I'll open it up to speakers, and you can just unmute yourself and share a little bit about your thoughts around kind of the workforce shortage and how telehealth can help with that. We have just about 2 or 3 minutes, so I'll pause.
Just very quickly, I can tell you for IHS, one of the great things that we've seen is being able to retain providers. Oftentimes, where providers have to work in the middle of reservations or in very remote areas, it's not viable for them to stay there for the long term with families, spouses, partners. And so I am specifically starting a program to that whenever a behavioral health provider needs to leave, that we can still keep them connected via telehealth to that community, but potentially to other communities as well. So we're really focusing on that retention piece and transitioning them from in-person services to teleservices to make sure that they can stay connected to that community and address other communities as well.
Thanks, Chris. That's great. Donna or Janet, anything on go ahead, Donna.
Yeah, I'd just like to chime in. Yes, definitely. Retention is so important, and strategies that improve provider satisfaction is important. And one of those, I think, is a team-based care model where you have provider extenders and behavioral health specialists and case management and patient navigators and peer supports that can support and supplement not only the individual's care, but also that feeling that providers often have that I am, the one and only person that can help when a client is supported by a team. I think that really makes a difference. We've also seen some success with organizations who have actually shared a provider across multiple organizations or multiple geographic locations, and allowing the provider to stay put in their base but serve different geographic locations. And so I think enabling providers to do their best in providing care while accessing services for the clients is essential.
Thank you. And Janet, maybe just 30 seconds, and then I know we have to transition.
Well, I do think that, I was talking about psychology being so small and the numbers, and it has been interesting that the states that have joined talk about we've now added 10,000 people that can come in and see our consumers, and how important that has been to them to have that extra support as they've needed it during the times.
Great, thank you. So thank you again to our wonderful speakers for today, and also to all of you for joining us. I just want to note that the session recordings and the PowerPoints will be available online. I think each of our speakers have very generously provided their email addresses if you have further questions, but the information will be available in a couple of days. So just as far as logistics, now we're going to move into a quick break. Invite you to come back at 3 o'clock Eastern time, and we'll be continuing the conference at that time. And the next session will be focused on telehealth research trends. And you can join the next session from the link in the agenda. So I hope you enjoy the rest of today's conference, and really appreciate everyone's time today. Take care.